Hello everyone. How are you? I'm so sorry, guys. So, yeah, I've been on and off for some time, right? So, but now I'm back here, right? So, we are gonna do renal pharmacology today, right? And if we have the time, we will do renal cancers as well, right? But there are so few people here, right? I hope more people join. Okay, guys. So today, first of all, the most important thing that we are going to do is the renal pharmacology, right? Why is renal pharmacology so important? Because renal pharmacology is important due to the fact that in renal pharmacology, right? So in renal pharmacology, there are a lot of drugs, right? And these drugs are not only important in the pharmacology, they integrate very well with the endocrinology, right? So they indeed. Let's just give me 1 second. Okay, guys. So, so I'm back, right? So the thing was that these drugs are going to integrate with the cardiovascular system as well as endocrinology as well, right? So this is the thing that is the most important here, right? This table is the most important table. Can all of you see my screen? Yeah. Okay. So there are very low students today. There are very less students today, right? So this table is the most important table, right? This table is the most important table here, right? What are the effects of diuretic on different electrolyte excretions, right? But you cannot just cram this table, right? You have to understand this table. You have to know how does this table work, how are different things going to work, right? How are they going to integrate with each other, right? So this table is the most important table here, right? And we are not going to do it now. First of all, we are going to do each of the individual diuretics, right? And after completing all of those diuretics, we are going to come back here. We are going to see what have we learned from that diuretics and what are the things that are still left behind that we have to focus on, right? So this is how we are gonna do today, right? So first of all, the most important diuretic is mannitol, right? Why is mannitol important? Mannitol is important because whenever you have any drug overdose, right? Whenever you have any drug overdose or whenever you have increase in intracranial pressure, you give the patients mannitol or acetazolamide, right? So, like, so what is increase intracranial pressure? Right? So whenever someone is having increased intracranial pressure, right? So if the intracranial pressure is increased, you can give the patients two drugs, right? One is mannitol and other is the acetazolamide, right? Now, why does mannitol become so important? Mannitol becomes so important because these are the only two things in which you can give the patients mannitol, right? Only in two conditions, only in increased intracranial pressure, right? Or only in drug overdose. These are the only two conditions in which you can give the patients mannitol, right? So normally we use diuretics. Diuretics are used a lot, right? And when do we use diuretics a lot? We use diuretics a lot whenever we are having pulmonary edema, right? Whenever we are having pulmonary edema, we are going to use diuretics to get all of the fluid out of the body, right? And when all of that fluid goes out of the body, you are going to get the pulmonary edema, right? So whenever that is our concern, we are going to use diuretics, right? But in case of mannitol, we cannot use that, right? We cannot use mannitol in case of pulmonary edema, right? Why is that? Right? So what does mannitol do? Right? So mannitol is very simple, right? Mannitol is an osmotic diuretic. What does it mean, right? So it means that it increases the osmolarity of the serum, right? It increases the osmolarity of the serum, right? And when the osmolarity of the serum or of the blood increases, right? So if this is the blood, right? Let me go ahead. Right? Uh, where was the other? Other book? Okay. This was the book. Right. So if this is the blood, right? And there are one, 10, 2 molecules, 3 molecules here, and 3 molecules here. No water is gonna move between this and so this is the tissue. So nothing is gonna move between this tissue. So the things that move here, there is not gonna be any movement, that movement here, right? So what is mannitol gonna do? Whenever we give the patient mannitol, mannitol is gonna stuck here, right? It's gonna get stuck here, and whenever there is increased amount of molecules somewhere, water is gonna follow. So water follows it, right? So as a result, first of all, the intravascular volume increases, right? The intravascular volume increases. This is the important thing that they want you to understand. First of all, in case of mannitol, the intravascular volume is going to increase. Right? When the intravascular volume is going to increase, right, then you are going to get increased amount of diuresis, right? You are going to get increased amount of diuresis, right? Because all the fluid from the tissues are going to go out, right? So, for example, why is this thing important? This thing is important because these are the blood vessels of the brain, and if this is the brain tissue, right? All of the blood from the brain tissue is going to go into the blood vessels, right? As a result, the brain is going to get cleared, right? As a result, the brain is going to get cleared. That is why mannitol is so important, right? Because whenever we are going to give the patients mannitol, this thing is going to happen. That is why mannitol is very good, right? But in case of pulmonary edema, right, you do not want increase in intravascular volume. Why? Because pulmonary edema normally occurs in those patients who are having heart failure, right? So these patients already have heart failure, right? If a patient already has heart failure, he already has a lot of blood in his blood vessels, right? We don't want increased amount of water or blood in that area. That is why we do not give that. Now, whenever we increase the amount of volume of blood, right, the glomerular filtration pressure is going to increase. When the glomerular filtration pressure is going to increase, you are going to get increased amount of urine, right? This is the most important way that it works, right? Now, the second thing is that this does not cause any natriuresis, right? This does not cause any natriuresis, right? It only leads to excretion of the water, right? It does not lead to the excretion of salt, right? No salt is excreted whenever a patient is taking mannitol. Right? Only water is secreted if a patient is taking mannitol. Right? Second thing is that now, what are the other important things, right? Other important things are that it's gonna cause the loss of water, right? So this is the only diuretic, right? So keep this side effect in your mind, right? This is the only diuretic that is gonna cause hypernatremia, right? Why is that? Because diuretics usually cause the loss of sodium, and whenever the sodium gets lost, the water is going to follow. Remember, guys, whenever sodium is lost from the body, water follows it. Right? Wherever sodium goes, water follows it. Right? So now, in this case, what is going to happen is that since only water is getting lost, and I have told you no salt is getting lost, right? So this amount of salt in comparison to the water is going to increase, right? The amount of salt in comparison to the water is going to increase, right? Now, when the amount of salt in comparison to the water is going to increase, you are going to get hypernatremia, right? You are going to get hypernatremia. So this is the first side effect, and this is how these things work, right? So this is the most important. And what are the conditions in which we give this thing? So we give it for acute glaucoma, right? So glaucoma is the most important indication, right? Second thing is that we give it in cerebral edema, right? So increase in coronary pressure or cerebral edema. And then the third thing is whenever we have drug overdose and we have to reverse the drug overdose, then we give it. And what are the contraindications? Remember the contraindications, right? Whenever a patient is having anuria, so for example, if the kidney is not working, we cannot give this. Right? And if there is heart failure or there is pulmonary edema, right? These are the only indications when you cannot give this medication. Right? Any questions, guys? Guys, can you hear me clearly?
Yes, we can.
Okay, so the next thing that we're gonna do is the carbonic anhydrase inhibitors, right? So guys, do you remember the physiology of carbonic anhydrase inhibitors? Yes or no? How do the carbonic anhydrase works? Do you want me to repeat it or not? Okay. Okay. So let me repeat it once again. Right. Let me repeat it once again because it's important. So can anyone tell me where does carbonic anhydrase inhibitors work? First thing, first things
Proximal
first.
convoluted tubule.
Proximal
Yes.
convoluted tube.
Yes, so it's going to work in the proximal convoluted tubule. Now, what is going to happen in the proximal convoluted tubule is a lot of important functions, right? And one of these functions is that we have a lot of carbon dioxide, right, and water here, right? So a lot of carbon dioxide is water and is present, in, right? And what is going to happen is that there is going to come an enzyme which is going to be known as carbonic anhydrase, and this carbonic anhydrase is going to form by carbonic acid, right? And then this carbonic acid is going to form H positive and HCO3. Right? Now, this is usually in equilibrium, right? This is usually in equilibrium because H positive ion is going to cancel HCO3 negative, right? Now, what happens is that this HCO3 negative is going to go back into the blood. It's going to get absorbed back into the blood. This HCO negative is going to get absorbed along with the help of sodium, right? So, whenever sodium gets absorbed, HCO3 negative, whenever HCO3 negative gets absorbed, sodium is automatically going to get absorbed, right? Again, whenever sodium is going to get absorbed, uh, or HCO3 negative is going to get absorbed, sodium is going to get absorbed automatically, right? So how can we fix this thing? Right? What can we do to end this thing, right? So it's very simple. And secondly, right, secondly, at the same time, this H positive ion is going to go outside, right? And sodium is going to come inwards from here. And this is the nephron side, right? So from the nephron, this is the second thing that is going to happen. Sodium is going to come into the cell, right, and S positive ion is going to go out, right? So if I ask you, what electrolytes do the carbonic anhydrase inhibitors affect and how, right? How? What are the electrolytes in what, right? What are the electrolytes that carbonic anhydrase inhibitors affect and how, right?
Bicarb absorption, because it affects over here in the carbonic acid is dissociated because of this enzyme
Yeah,
into the hydrogen ion and bicarb.
yeah. So bicarb. Any other electrolyte that is affected?
uh, Hydrogen ion also.
Yes, so hydrogen ion and sodium ion, right? So now what is going to happen is that carbonic anhydrases increases the absorption so by carb. It increases the absorption of sodium, right? And it decreases the absorption of H positive, right? This is all the things that the carbonic anhydrase inhibitors do. And that is why carbonic anhydrase inhibitors are so important to us, right? But now carbonic anhydrases are so important. But now what if we block all of this process, right? If this all of these process gets blocked, no HCO3 negative ions are going to be absorbed, right? The HCO3 levels are going to decrease, right? Sodium levels in the blood are going to decrease, right? And H positives are going to go high, right? So these are the side effects of carbonic anhydrase inhibitors, right? So you are going to get metabolic acidosis, right? You are going to get, so this is how it's going to work, right? It's going to block, so basically, uh, it's going to increase the absorption of H positive, right? So H positive of reabsorption is going to be increased. Bicarbonate excretion is going to increase. Sodium excretion is going to increase. Right? Now, why is this thing important? Right? This thing is important because, for example, if I'm telling you that a lot of bicarbonates are getting secreted out, right? What do you think the patient is going to have? Right? What acid-base abnormality will the patient have?
Metabolic acid.
Yes, so the patient is gonna get acidosis, right? And what is the control? What is the compensation for metabolic acidosis? Anyone?
Re- Respiratory alkalosis.
Decrease.
Yes,
Yes, increase respiratory rate.
yes. So there is going to be
Hyper
yes, so there is going to
hy-
be compensatory hyperventilation. Right? People-
Hyperventilation and
Yes, so this is
yeah.
gonna be hyperventilation, right? But why is this hyperventilation? This hyperventilation is important because right? So it's going to increase hyperventilation and it's going to decrease the carbon dioxide and oxygen is going to increase, right? This is the side effect that we are going to have due to carbonic anhydrase inhibitors. But this thing comes to our benefit. How does this thing comes to our benefit? This thing comes to our benefit due to the fact that oxygenation is going to increase. So, for example, if a person is going to mountains, right? So their oxygen is already very low, right? So if a patient is going to mountains, the O2 levels are very low, yeah, and CO2 levels are high. So in order to combat that, we can start giving the patients hyper. We can start giving the patients hypochlorite, right? And this is going to help us a lot, right? It's going to prevent periods of extreme hypoxia, right? It's going to prevent the periods of extreme hypoxia, right? So we using it in prevention of mountain sickness, right? So we use this thing in the prevention of mountain sickness, right? Or altitude sickness, right? So any questions? No fire coming the properties of the Okay, very good question, right? So I'll get into the detail of it, right? And I'm gonna get into the detail of it, right? Uh, okay. So first of all, in order to do that, we have to go over potassium sparing diuretics, right? So let me just finish it and yes, let me first finish it and then we'll go over the potassium sparing diuretics and then we are gonna do it, right? Okay. So now the next thing is that again, this is gonna be used in glaucoma, right? So what are the two diuretics that are used in glaucoma, right? So this is one and the other one is that, right? Now the most important side effect that this thing is gonna happen, this thing is gonna have is that when you are uh, you are gonna get renal tubular acidosis, right? So you're gonna get acidosis. So first of all, you're gonna get metabolic. What are the side effects? The number one side effect is you're gonna get metabolic acidosis. That was pretty clear, right? You're gonna get metabolic acidosis, right? The most important thing is that you're gonna get calcium phosphate stones. Right? You're gonna get calcium phosphate stones. Keep this thing in mind and they ask it again and again and again. Why do acetazolamide, why do carbonic anhydrase inhibitors lead to calcium phosphate formation? Why? Because calcium phosphate stones form when there is alkaline environment, right? So keep this thing in mind. So have you guys covered the kidney stones? Right, the kidney stones are very important. Were they covered completely? Okay. So remember, there were two kidney stones. The main thing was that some kidney stones were formed in acidic environment. Some kidney stones were formed in acidic, and some kidney stones were formed in the alkaline environment. Right? So what were the kidney stones that are formed in alkaline environment? So uric acid is formed in acidic environment, right? So in order to prevent the formation of uric acid stones, we give alkalization of the urine. Do alkalization of the urine. Whereas in case of alkaline urine, right, calcium phosphate stones are going to be formed, right? You are going to have calcium phosphate stones, right? Calcium phosphate stones are going to be formed, right? And what alkalizes the urine, right? So whenever we give the patients carbonic anhydrase inhibitors, since HCO3 negative ion is not going to get absorbed, it is going to cause the urine to get alkalinized, right? It is going to cause the urine to get alkalinized, right? Okay. So basically, these are the very important side effects. These are the side effects that you should always keep in your mind. Right? So there are characteristic side effects of every diuretic. Right? There's very characteristic side effects of every diuretic, and you have to keep this in mind, right? So remember, acetazolamide alkalinizes the urine, right? This is the first thing. Second thing is that it is going to cause metabolic acidosis, right? Third thing is that it's going to cause the formation of calcium phosphate, right? Another thing is that it lead it leads to NH3, increased levels of NH3, right? And that means it's gonna cause hyperammonemia. Right? It's gonna lead to hyperammonemia. This is the other side of it that you have to know, right? So any questions till now, guys? If not, then I'm gonna move forward the potassium strain diuretics first. Okay, guys, I have another question for you, right? What time works best for you guys? What time works best for you? So we can have classes at that time because I am seeing that only 20 people have joined the class, right? And I think it's even late for the US students, right? So what time will work best for you guys? Because I think so even at that time, not at 10:30 p.m., a lot of Pakistani students cannot join. Yes, it's 11 p.m. here, very late. Exactly. It's very late. It's 11 p.m. for me as well, and it's very late for me as well. I have to go work 4:30 in the morning. Yep. So what time works for you? Dr. Y or anyone, Dr. Zameen? What time works better for you? The previous time that was at start. Okay. Okay. We'll do sometimes related to that. Okay. Sure. So that time was what was that time exactly?
That
It was
was 11 a.m. Eastern.
I said,
Yeah, this
okay,
time
we'll
is
do
fine.
some.
This time
Okay,
is
we'll
fine.
yeah. Don't worry, I don't worry, guys. I'll work around my resident schedules, right? I have promised that I would complete this marathon of yours, right? And I'm not here with you in this marathon, right? Even in the NBM itself. So till you guys get 76 or 77% in your NBM itself, I'm here with you guys, right? So my goal is 77% plus, right? You can easily give the exam after 68%, right? But I always strive for 77% plus. Why? Because it's gonna help you in step two as well, right? It's gonna have a good basis of your stepping, right? Okay, so now we are gonna move to the potassium sparing diuretics, right? So what were the potassium sparing diuretics? So basically, we had the aldosterone, right? So in the collecting tubules, right? In the collecting tubules and in the collecting ducts, right? In the collecting tubules and in the collecting ducts, we have spironolactone or epinephrine. So we had aldosterone, right? So aldosterone came here and aldosterone. Right. So remember, in different reviews, different things were acting, right? In different parts of nephron, different things were going on. Right. And you have to keep in mind that what part of nephron, what thing was going on. Right. So you have to keep in mind that in what part of nephron, what thing was going on. In the collecting duct, aldosterone was acting, right? And what was aldosterone causes? Aldosterone was causing increased sodium reabsorption, right? It was decreasing potassium levels, right? And at the same time, it was causing H positive ion sugar loss. Like it was causing, right? So these were all of the things that it was causing, right? Now, we got some diuretics, right? So scientists discovered, the medicine clinicians discovered some diuretics, and they thought that so now there are four types. So we divide the potassium filling diuretics into two types, right? So they are exactly types. So the number one is those that work on the aldosterone receptor. So the number one are those that act on the aldosterone receptor. Right? And what are those? Those are the spironolactones, right? So we have spironolactone and eplerenone, right? These are gonna act on the aldosterone receptors, right? Whereas we have ENaC channels as well, that were the sodium channels, right? And triamtrene, right? And amyloid worked on this, right? Now, I'm telling you these are why are these important? I'm gonna go into the detail of each of these in a second, right? Now, first of all, so aldosterone decreased potassium, right? Right. Right. So, do you have any idea if we are giving a so what is going to happen? And, so basically, it's going to cause. So, whenever we are going to give the patient, whenever we give the patient aldosterone receptor antagonist, which is called like that level, the potassium level in the body will increase. Right? The potassium level in the body. Okay. It's, okay. Okay. Okay, so I was saying that whenever we give the patient spironolactone or whenever we give the patient aldosterone receptor antagonist, what is going to happen, right? So whenever we give the patient aldosterone receptor antagonist, the main thing that is going to happen is that the potassium excretion is going to increase in the body, right? The potassium excretion in the body is going to increase, right? Is going to decrease, right? The potassium excretion in the body is going to increase, right? So potassium gets excreted. Right? Let's write it like that. That's right. Potassium gets excreted. Keep this thing in mind. Right? Potassium is going to get excreted, right? Whenever you give the patient aldosterone receptor antagonist, right? At the same time, H positive excretion is going to decrease, right? H positive excretion is going to decrease as well, right? And this is going to cause acidosis. Okay. So these are the two important things that I. Now, one important thing that is here that we have an important drug which is known as spironolactone, which is again an aldosterone receptor antagonist. But this spironolactone also acts on the sex hormone receptors. This also acts on the sex hormone receptors, right? So it is an antagonist of testosterone. It is an antagonist of estrogen as well, right? And whenever the spironolactone, whenever you give this spironolactone, the male patients are going to complain of gynecomastia. Right? The main patients are going to complain. Okay. Gynecomastia, the main patients are going to say that I'm in decreased libido. Now, these are things that the patient is going to complain. Right? These are the first most important things that the patient is going to compare of. Now remember, I told you again regarding every diuretic, you have to look at the metabolic abnormalities. You have to look at what metabolic abnormalities are present. And if you look here, the patient is going to have hyperkalemia, right? The patient is going to have hyperkalemia, and the patient is going to have acidosis as well. Right? And if you're giving the patient spironolactone, then the patient is going to have gynecomastia. The male patient is going to have erectile dysfunction as well. Female patient is going to have amenorrhea as well. These are all the things that the patients are going to have. Now, coming back to the question of Dr. Goel, right? Coming back to the question. Okay. Okay. So now, what was happening in case of altitude sickness? What was happening in case of altitude sickness? So whenever a patient was suffering from altitude sickness, the main thing that was happening was that at high altitudes there was less amount of oxygen. Right? When the oxygen was reduced, we were getting hyperventilation. Right? We are going to go into the detail of this in terminology. Right? So whenever the oxygen was reduced, we were getting hyperventilation. And when there was hyperventilation, we were getting respiratory alkalosis. Right? Now we have to fix this thing. And in order to fix this thing, we had to remove HCO3 negative from the body. And what was the drug that can remove HCO3? So because in alkalosis, the HCO3 negative ions are going to go high, right? So we have to remove the amount of HCO3 negative, right? So in order to remove the HCO3 negative, we give patients acetazolamide. And that is going to counteract the respiratory alkalosis. Now, okay, why can't we give the patient potassium sparing diuretics? Because I've already told you that potassium sparing diuretics does not affect bicarbonate. It's going to affect the H positive excretion. Right? And we do not want anything with the H positive excretion. Right? They do not cause any of such things. Right? We just need to increase the amount of so this is going to cause decrease the amount of H positive excretion. Right? This is the way this is going to happen, right? If you look at acetazolamide, that is going to work on the HCO3 negative part, whereas if you look at the potassium sparing diuretics, it's going to work on the other part. That is all. Now, what are the indications of potassium sparing diuretics, right? So normally we give potassium sparing diuretics when we want hypokalemia and treatment of hypertension at the same time. And these are step 2 level stuff, right? These are not that important, right? But one thing that is very, 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 very important is that whenever a patient is having, so we can, no, no, let's go back to my original stuff, right? So, for example, they give you a question and they say that a 30 or 40-year-old male comes to you and that male is having, so, right? They give you a patient and a 30 or 40-year-old male patient comes to you. And that patient is sometimes depressed and that patient is sometimes very good, right? That patient is sometimes smiling, right? And you start to give the patient some kind of medications for treatment of this patient, right? So sometimes the patient speaks a lot, sometimes the patient has pressure issues, right? Sometimes the patient is violent, sometimes patient has this flight of ideas, but at the times the patient is very sad, And you start to give some treatment for this patient, and now this patient is having very much increased amount of urination, right? And then they could say, which of the following diuretic what do you give to this person, right? What is the diuretic that you would give to this person? And now you would get into thinking, right? How the hell is a diuretic going to help this condition, right? So remember, this diagnosis is the diagnosis of nephrogenic diabetic insipidus. Right? This is the diagnosis of nephrogenic diabetic insipidus. So basically, this is nephrogenic diabetes insipidus, and especially due to medium, it's going to happen. Okay, this is only basically happening due to medium, and when this is happening due to medium, what is the treatment for this? The treatment for this is potassium-sparing diuretic, that is amyloid. And then if they ask you what is the mechanism of action of this, it belongs to ENaC channels, right? Why are these ENaC channels important? Because whenever you are taking the patient is taking medium, right? Then the in the collecting tubules, right? So in the collecting tubules, ADS is gonna work, right? So this is the ENaC channel, right? This is the ENaC channel, and lithium is gonna come here, right? And lithium is gonna act on these ENaC channels. They go inside and destroy the ADH receptors, right? But if we give patient an this ENaC channel is gonna get blocked. No. If we give the patient a Milleroid, this ENaC channel is gonna get blocked, and when this ENaC channel is gonna gets blocked, right? You are gonna get the treatment of nephrogenic diabetes insipidus, right? Right. Now, we sometimes use spironolactone for hyperandrogenism as well. So if a patient is having polycystic ovarian syndrome, or if a patient is male patient is having cancer, or if you are having hirsutism, an increased amount of hair that is present on the chin, then in that part we use spironolactone as well. Right? Any questions, guys? Okay. So do you want to repeat it with regards to the amyloid or regarding the
Amiloride.
okay, so remember, so basically, so basically remember that uh, this is a very telltale question, right? They love this question, and they love to test the association of bipolar disorder in your exams, right? The USMLEs, the UWorlds, and VMEs, all of those love to test the association of bipolar disorder because bipolar disorder is so prevalent here, right? Whenever I'm traveling there, whenever I'm looking into the subways, when I'm going to the subways, right? I see a lot of patients of bipolar. These bipolar patients are not that prevalent in other parts of the world, especially in Asia and Middle East. But here in US, they are very prevalent. That is why they ask the questions about bipolar disorder. Okay. Okay. So this is how. So now they're going to give you a patient. They're going to say that the patient was having bipolar disorder. Right? They're going to say that the patient was having bipolar disorder, and that patient wants some kind of treatment for the bipolar, or they can just give you the signs and symptoms of bipolar disorder. And now they're going to say that this patient is being treated for this condition, and now this patient is having increased amount of urination. First thing is that this patient is having nephrogenic diabetes insipidus. Right? This is the first thing that you're going to know that this patient was suffering from nephrogenic diabetes insipidus. Okay, guys. So is that thing clear? First, now, why does lithium cause nephrogenic diabetes insipidus? We have these collecting ducts, right? And in the collecting ducts, we have ENaC channels, right? So these channels are the channels that absorb sodium, right? So ENaC channels are the channels that are going to absorb sodium. And how do these channels absorb sodium? So basically, lithium is going to come in through this channel, right? So lithium is going to come into this channel right here, right? And it's going to go in and it's going to destroy the ADH, right? This is how medium destroys the collecting duct and the collecting tubule, and this is how it's going to cause a lot of problems, right? So how can we do to fix this thing? What can we do to fix this thing? We can block this ENaC channel, right? So we can block this channel so nothing gets to it, especially medium, right? And in order to block this channel, you have to give a blocker of renal channel. And what is the blocker of the renal channel? So the blocker of renal channel is amyloid. Right? So amyloid is a blocker of renal channels. Right? So we give the patients amyloid, and as soon as we give the patients amyloid, the patient is going through. Okay, guys. Any questions? Okay. No, no, you're welcome. You're welcome. I'm sorry, guys. My voice is a bit sleepy, I think. Right? Now we have the most easiest. We have the thyroid diuretics.
Sorry, sorry, Dr. Moaz.
Yep.
Since tramtaine can also block the same channel, can we use both in bipolar disorder?
Okay. So your question is why don't we use priamprine and why do we use only amyloid, right?
No, I mean, can we use both in bipolar
Okay.
with
So for
inpatient that is having diabetes insipidus?
okay. Yeah, basically, yeah, yes, right. So yes, so basically we can use both, right? We can use a Milleroid, right? We can use that as well, right? But normally, uh, so basically, remember, guys, right? Whenever we are studying a drugs, right? Whenever we are studying a lot of drugs, they're gonna give us a name of a lot of drugs, right? So for renal channel blockers, there are going to be a lot of blockers, right? Similarly, there are going to be thousands of NSAIDs, right? So yes, we can use triamtrene, right? But there is one major thing, right? Triamtrene is a weak blocker of NS promise, right? It's a weak blocker of NS promise, right? Second thing is that it is nephrotoxic, right? So basically, in theory, right? In theory, it does work on the NAC channels and it does block it, right? But it is very nephrotoxic and intense, so we do not use it in reality, right? So in reality, triamtrene is a drug that is never used, right? So that is why we do not use it. But you are right, right? So basically, from the standpoint of USMLE, specifically, you can use triamtrene as well as amyloid. But amyloid is going to be the right answer because the test is the most important, right? So basically, we just want the medium not to get into cell, right? Please keep this thing in mind. This is very high. There are going to be a lot of questions on this one, right? This is very high. There is going to be a lot of questions on this one. Now let's move on to the other topic. That is thyroid diabetes, right? Now, how do thyroid diuretics work, right? The thyroid diuretics are very simple. They are going to act in a distal convoluted tubule. They are going to lock the absorption of sodium chloride, right? At the same time, they decrease the calcium excretion, right? So they're going to increase the calcium absorption. And I've gone into the detail of how does it causes the problems with calcium, right? How does it lead to calcium problems? And how it solves different calcium problems, right? Now, basically, remember regarding two things, right? Thiazides and loops, they are almost same. Right? Thiazide and loops, they are almost same. They are going to cause the same things. They are going to cause hypokalemia, right? They are going to cause alkalosis, right? They are going to cause hypokalemia. They are going to cause alkalosis, right? They are going to cause hyponatremia as well, right? These are the things that both of these things are going to do. Right? You're going to do hyponatremia, hypolosis, hypokalemia, all of these things, right? The only difference is that thiazides also lead to hyperglycemia, hyperuricemia as well. Why is this thing important? So this thing is important because if a patient is suffering from diabetes, right, we usually avoid giving them thiazide diuretics. Right? Again, if a patient is suffering from diabetes insipidus, right, or sorry, diabetes mellitus, right? So if a patient is suffering from diabetes mellitus, we usually avoid giving these patients thiazide diuretics, right? Why? Because it's going to worsen the diabetic profile of the patient, right? So keep this station in mind, which diuretic is mildly contraindicated in patients, right, of diabetes. So that is going to be thiazide, hydrochlorothiazide, chlorothiazide, chlorothiazide, or metazolam, right? And what's the mechanism of action? It's going to block the sodium chloride co-transporter, right? And the side effects are very important. It's going to cause hypokalemia. It's going to cause alkalosis. It's going to cause hyponatremia. It's going to cause hypercalcemia because of the. So remember, what's the main difference between loops and thiazide? Loops. So remember, thiazides. So remember, thiazides decrease the absorption of thiazides increase absorption of calcium, right? They increase the absorption of calcium. Right? right? That increases the absorption of calcium, yeah. Whereas loops decrease the absorption of calcium. Okay, guys, is this clear to you? Okay, okay. So
Mhm.
remember, decrease, please keep this thing in mind, right? If you have to decrease calcium from the body, you are going to give loops. If you have to increase calcium in the body, you have to give thiazides. So for the treatment of kidney stones, we usually give thiazides, right? Because kidney stones are going, so kidney stones are going to occur in the urine, right? Kidney stones are going to occur in the urine, and in order to prevent this, you have to give thiazides. Right? This is the basic difference between both of these, right? So these are the, so now for loops, just remember loops are going to act only, the loops are going to act on the sodium, potassium, chloride, two chloride sulfate. We're gonna go into the so I tomorrow we'll have a big session, right? So tomorrow we'll have a good session and a big session, and in that we're gonna go into the detail of so renal is gonna be finished, right? So I'm gonna I will be participating in these temple along with Dr. Imad. I will cover a lot of topics as well. So I know I wasn't here in the beginning, but I'm gonna come back and cover a lot of topics, right? What I remember that for prosperous, I almost said the task before. Sustainably happened because it could be vaccinated. I think his blood is
Dr.
getting,
Moaz, Dr. Moaz,
yes.
your voice is not too clear. Your
Okay,
voice
okay. Is it breaking or is it not clear?
It's
is
breaking.
is breaking.
Okay, 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 okay. Uh, okay, okay. I'll try to fix it. It's okay. And that, let me read the question. No, no. I'm so sorry. So yes, so I'm gonna fix the time right as well, right? So 10:30. Obviously, it's late for the US students as well as for Pakistani students, right? So we are gonna do some other time. That works for both. Right. So guys, remember, Dr. Y, the problem that is gonna occur in the system urea is gonna be in the proximal lumen interface, right? You're gonna absorb all of these things, right? You're gonna absorb all of these, right? It's not going to occur in the level of intestines, right? Intestines are going to be normal, right? So you're going to absorb all of those things, right? And the transporters for cysteine in the intestine and the transporter for cysteine in the proximal conjugated tubule are different, right? They're different from one another, right? So they're very different, right? So these are different, right? So basically, this is going to occur at only at that point, right? So I think the transporter name was SLC3A1, right? So this is not important for the exam I'm just telling you, right? So this was the transporter that was affected. So for the SLC3A1 and SLC7 and 9. So both of these were affected and both of these are present in the optimal conjugate. And those transporters that were present in visual and they were not affected. Obviously, they were not affected and they were not causing any problem. Right? Now we can do genetic testing as well to confirm this. We usually do not do that. Right? Now, right. Okay. Now, any other questions, guys? You can ask me any questions, right? So angiotensin, so ACE inhibitors and ARBs, I think we have already gone into the detail of these things a lot, right? In the physiology portion, I've told you that how ACE inhibitors inhibit ACE, then angiotensin gets low, then how does GFR gets affected, how is the angina going to happen, the angioedema going to happen, how is going to reduce the mortality, how it affects all of those things, right? Any questions regarding those things in ACE inhibitors and ARBs? What I was thinking of doing was that I was thinking you could tell me all of the questions, all of the topics that you think are weak, right? And we can cover it in 1 or 2 days or 3 days, right? if you guys want to do that. If you think that there was somehow you dropping that, that's okay. And because of this, I was not really doing my own problems, right? So we can do that. We can do those topics as well. And we can cover those topics as well. Anyway, okay. Now, let's do the winners. Okay. So I think winners like Arsenal is good. Right. So guys, I think we'll keep our lecture here till here today. I'm gonna set a suitable time for tomorrow, right? Which is gonna be better for all of us, right? So and then even if the residency time is unpredictable, I'll tell you beforehand what options do we have, and we'll try to find some good options, right? So we'll keep our lecture till here today, and tomorrow we are gonna do the concepts, right? Okay. So take care, guys, and bye.
Anyone there? Hello? 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 Good night. Hello?